Hello, my name is Klaus Roehrborn, and I'm professor and chair of the Department of Urology at UT Southwestern in Dallas, Texas. And with me today is Ken Goldberg, associate professor in the Department of Urology. Today we talk a little bit about something we do in urology quite commonly, namely flow rate recording, how it's done, why it's done, when it's done, the shortcomings of it, and how we might find ways to improve it. Now, I have been all my academic life part of the AUA guideline process, and the AUA BPH guidelines recommend actually a flow rate recording in men with LUTS and BPH early on in the evaluation if the equipment is available. But even if it's not readily available, the guidelines actually admonish us to do a flow rate recording and residual urine check if we change treatment, if symptoms get worse, or if a patient is considering surgical treatment. So Ken, you practiced 40 years, 4 decades, a very long time. Tell me, how do you use the flow rate recording in your practice?
Well, Klaus, I think flow rates are an objective way of determining what a man says when he says his flow is good or weak, or he's having issues. It's so hard to put anything to these vague types of responses. So flow rates can help you. They can make a big difference, and I have through the years relied on them. They're actually objective metrics that we can use to assess a man: improvement, deterioration, or stability.
So let's dissect a little bit. The guidelines really only state the initial evaluation. That's sort of the dilemma of all the guidelines, really. But that's not all we do. We have patients on active surveillance or watchful waiting. And so do you use it there to monitor how they progress?
More so at the current time only when there's a change, because there's an expense. We'll get into some of the issues about office flowmetry. So not really unless there's a change.
What about medical therapies? So many men are taking alpha blockers, they take in 5-FARIs or combination therapy. You have men on anticholinergics. Do you check the flow rate together with a residual urine?
We would be tying up 2 bathrooms continuously, trying to do that, waiting for them to go, cleaning up the messes in the bathrooms, et cetera, so forth. So it isn't practical, certainly, to do it. It would be nice. It would be nice to give a man an OAB drug and say, go, let's check your flow and see how you're doing. 1 alpha blocker tablet isn't enough. Maybe you should try 2. The PDE5s may help. Let's see, but there just isn't the practicality to do that.
But there is monitoring, at least let's just say before and then after surgical treatment, or is that certainly what you'll do?
There should be, for sure. I think to try to determine if you think you can help someone, you have to identify what his real problem is. We all know most men have an issue with nocturia as their main complaint, but how many of them really have an obstruction that needs to be dealt with from an interventional point of view? So I rely, certainly, I won't do any procedure on anyone without it, unless they're obviously a retention, then there's not necessarily a need, but otherwise we do. We should have that.
So most the flow rate meters that we use in the practice, they are based on this spinning disc mechanism. So the patient urinates and the flow rate is recorded. We check the peak urinary flow rate. The voided volume is recorded. We do put the patient in a private bathroom and we say, don't worry, we close the door, nobody's walking in. But there are problems with this in the clinical practice. So what in your experience are some of the problems associated with a flow rate recording in the practice, in the office setting?
I think there's a number of issues with it. The first is studies have shown 50% of the time a man doesn't have a volume of at least 150 cc's when he goes, so technically it's not accurate. Many men aren't ready to go. Maybe they avoided on the way in, maybe they got stuck in traffic, or maybe they forgot they were supposed to, so they tie up the waiting room, they tie up the exam room. Certainly with a recent pandemic, you don't want men hanging around the office, so you have a lot of men who aren't ready to do flows. You have the overachievers. The men who over-distend their bladder, maybe they have 700, 800 in because they really want to impress you or show that they can perform. And in fact, their flow rate is horrible because their compliance is gone.
So there are logistical issues. And then patients oftentimes, they tell me, that wasn't really me. I did this, but that wasn't really me. At home, everything looks different. You had that too.
Oh, for sure. And let alone the mess the bathroom has, and the staff has to clean it up. I mean, there's a number of issues with it, but yes, it's a metric that we've come to rely on.
So I just, in preparation for this conversation, I just had a patient in my office this week, and he had a TURP. And I thought he had a good TURP. Everything went well. He came in for the flow rate. He probably wasn't ready. He had a little nervousness, anxiety. And I'll play a little video. I think that highlights the problems we are facing.
I failed. This is not typical of what I have been experiencing since the surgery.
And so the volume was quite low today, and at home it's usually better?
Oh, yes. And the flow, you had told me after my surgery that I'd probably be urinating like a 14-year-old, and I do. I have a strong stream. It finishes. I'm pleased with my flow.
All right. And so it's just in the doctor's office, the pressure and the timing isn't right and that kind of thing.
I did drink liquids and such, but I'm trying to meet the deadline with you, and it just didn't work.
And it's understandable, and you're not the only patient, believe me. So despite of those problems, that number that comes out of it, the maximum flow rate, it is a big to-do, because we learned from Paul Abrams that if a man has a peak flow at over 15 milliliter, unlikely to be obstructed. Under 10 milliliter per second, much more likely to be obstructed. And we learn, and the guidelines say, if the patient is obstructed, you should consider surgical intervention, unobstruction. So this brings up this problem of the reproducibility and relying on a single value, doesn't it?
It does, and we also have the issue of these artifacts that we will see and get this rapid spiking down, which doesn't last 2 seconds, and the flow rate may be 30, but every other part of his flow rate's down in the 10 or 12s. And I recently found out, and didn't know, that the International Continence Society recommends calibration of flow rates every year, and I'm not aware that my flow rates have ever been calibrated. And I'm sure most urologists weren't aware of that as well. So we're basing our information and our decision-making on one simple example in the office.
That could be flawed due to the patient being poorly prepared, due to the patient being overly anxious and nervous. Does a patient have a high blood pressure in the office, and they call it white coat hypertension? And why wouldn't a patient think, wow, whatever the doctor says and does to me may depend on how good I do on this flow rate? So the patients are nervous naturally.
For sure.
So you researched this a little bit, and you came up with something that is maybe a surprise to many of the folks who listened to this interview. You found out that there are alternatives, and name a few, and how do they work, these alternatives?
When the pandemic struck and we weren't able to see patients in the office, trying to monitor patients at home, it gets back to the old flows good, flows not, and I really felt we had to have a better way. And I started looking online, and lo and behold, there were different options out there. There actually is a little device that's mailed to the patient. He gets to keep it, does some flow rates, and mails it back, and the urologist gets it. And that actually, some 16,000 flow rates was published in the Journal of Urology last year. That's called StreamDx. There are these handheld devices or that someone can urinate into and creates data that can get to the urologist. There's a similar to a urinary flow rate that they can actually put in the commode and get a flow rate, again, getting the information.
So that's actually taken like almost what we know as a spinning disc kind of container, taking that and a cheap version of it, if you will, giving it to the patient to use it at home.
Correct, and let them deal with it and all the apparatus and the urine and the storage and the cleaning of it. And so I came across that there actually are apps out there that can be used to monitor home flow rates based on sound.
No, that's that's the innovation, right? And I think this is basically what this little brochure talks about. So this is an app, if I understand it. There is not really a device associated with it called ProudP. And the patient takes this home. It comes with instructions how to use it. And they have to have an app on their phone, right?
Correct. And in fact, I have an app for the ProudP. It's very simple. They download the app. They register for the urologist that they're seeing, so that.
So how safe and secure is that? I mean, there is a unique code for each urologist,
gets for his patients.
For his patient.
I'm sure you could probably do one for a clinic, but each urologist can get his own code.
Right.
So that's unique. The patient just puts his name and birth date in, no other demographics. They are working on more symptom scores and medications and surgery.
Sure, but right now it's the flow rate.
It's the flow rate and the volume.
So walk me through it. So the patient
Downloads the app.
The patient has to have an iPhone.
Correct. iPhone 8 or higher. He downloads the app, puts in your clinic code, puts in his demographic information, can do some of the symptom scores and some of the other things we have. He goes into a toilet. It can't be a urinal, but a toilet.
Let's just play this through. This is different from the office, right? In the office, we tell the patient, we need you to do a flow rate. Here's the flow rate meter. Go there, pee in that machine,
That's right.
and it better come out good.
That's right.
And now we're at home. The patient sits down for dinner, and he says, well, honey, I got to go urinate. Takes his iPhone, he marches in there, and then what does he do?
He puts the phone, opens the app, gets it ready, simply says, ready, hits the button, gets a 3-second countdown, and can start to go. And once he's completed going, he just presses stop, and that's it.
So that's based on sound.
Sound.
And so even though this may sound
Milliseconds
gross,
of
it's a sound
It's a
of the
sound.
urine hitting the toilet bowl. So we have to have a toilet bowl with a water level.
Correct.
It hits that. And there can't be too much environmental noise, I don't guess,
sure.
right? And the phone has to be in a certain proximity, and the microphone has to be obviously open and accessible.
Correct.
So that sounds interesting and kind of wild. So what did the company do to validate this, if you will, to make sure this really measures what we are used to? It comes in the same ballpark.
Well, they did a couple of things. First thing they had to validate was, is there a distance and can it record at a certain level and distance? And so they actually reproduced sounds having 20, 30 full rate iPhones set up on stands and measured and got consistent results. And not only flow, but volume. Consistency with their volumes, almost close to a straight correlation.
So let me ask you this question. So I get it. They validated that the phone records the flow rate, and the volume that it records actually is the volume the patient urinated. And so how did they validate that the peak flow rate, which is a crucial number according to Paul Abrams, and others, how did they validate that that's roughly okay?
By measuring the rate of change in weight in the special commercial toilet with a scale on it, and by also having separate studies with volunteers who did a number of flow rates with the regular flow meter we have in the office and also with the iPhone.
So those are the two parameters that are
Correct.
really vital, because once you have voided volume and you have the peak flow rate, the phone knows, of course, the time because
Correct.
it's turned on and off. So with that, you can calculate your average flow rate. And so you have all the key parameters.
Voiding time, and you get a tracing
Yeah.
that gives you the flow rate, and it's in milliseconds of data that they're able to
Right. And has there been work done on the responsiveness? That's the characteristics of a diagnostic test. Is it responsive? Have there been studies done to look at patients off medication, on medication, before a resume, after a resume? Have there been studies published already?
The only study that, it actually is at the AUA for this year in moderated poster, is one that we from UT have put together, looking at this and seeing the variability that many men have. 37% of men had at least one flow rate below 10. 15% had at least 10% of their flow rates less than 10. So certainly there are studies starting to be done, and certainly more need to be done.
But no therapy responsiveness studies
Not
yet.
currently, but when you stop and recognize all the parameters and metrics, if you can get their medications, you can get their symptom scores, you can get their flow rates, you can start really digging in and seeing, okay, someone with the obstructive points on the IPPS and the men on the overactive type symptoms, one can actually correlate this and really just get an enormous amount of data and information and insight into a patient's actual voiding habit. Another interesting thing is the dysfunctional voider, or the patient with dysinertia, for lack of a better word. You actually can see them hit the button and almost a 5-10 second delay consistently before they're able to relax to go. So I found that another interesting little intriguing piece of information.
So not yet any therapeutic responsiveness studies, but easy to do, before, after treatment, before, after surgery. Or let's just take an example. A patient has a stricture, and let's just say we dilate the stricture. So it's always risky because it could stricture up again, the scar could reform. So I could see that if a patient lives a little bit away, 50 miles, and if he does a couple of flow rates every weekend and uploads them, I would know when he's heading to trouble.
As he would. As he
Yeah.
would as well.
Right.
And certainly I've taken it, I use Resume in my practice and have patients come from all over the state and even out of state, and I find it an intriguing way of following a patient. We get the pre-procedure flow rates, we start getting them after his catheter's been removed, and I can monitor him and determine when to get him off alpha blockers, when to get him off anti-inflammatories, and how he's doing at 3 months, 6 months, et cetera, so forth. And so I find that works well just from the point of view of convenience and keeps patients out of the office.
So you have a vast number of flow rates. When you say you, it's actually your patients have them,
correct.
but it's in your database on your web. But in any case, so let's look at a few examples. You told me before that it's kind of remarkable. Many patients urinate over and over and over, and it's like a fingerprint. The flow rate curve looks very similar. I think you had one patient who always has a very strong flow rate, always a similar volume of 350 milliliters, and always a good flow rate. I think we're looking at an example like that here, right?
It is, and you have those type patients, and you have other patients who consistently void either small volumes or consistently void with low flow rates.
Like the patient we're looking at here. So this also is interesting because a patient in the office voiding a small volume, he may say, well, that's just today, that's just in the office. But if the patient at home, where he has all the leisure and all the access to the toilet that he wants, if he always voids under 100 cc's, we know that patient has OAB.
For sure.
He has frequency, urgency, and that's his problem, right? I mean, it may not be the prostate, but it may be that. So that's a good example.
So there are men that I've come to see who are really variable in their flow rates.
Right.
And they can vary by as much as 10 cc's a second at the same volume.
And so that brings up another question. How does that vary, for example, time of day?
We see the volumes are pretty consistent, that different volumes can make a difference. Certainly for some men, during the night they do. In fact, we've all heard this, that their flow rates work worse at night, and we can see that. Other men, our flow rates worse in the morning, and we can actually validate this. So this is real-world experience.
Real-world experience, yeah. And so getting back to the patient, I showed that little interview clip who was frustrated with his performance. I think patients, still, even in the old days, patients kind of want to please the doctor, or they want to basically please themselves, and we would tell them, this wasn't really good. My patient, he was really disappointed. I think we have an example here of a patient you did a procedure on, and he had a really poor flow rate. Here we're looking at this flow rate. It's just 75 milliliters at a pretty low flow, 8.2. That would still be obstructed. But then you send him home with the Proud P app, and
his flow, max flow, is significantly better, and it becomes scary because you can make clinical decisions based on inaccurate data.
Right. So, to play this out a little bit, and here shows the example of his flow rates at home, quite a bit better and reproducible. Really interesting. So multiple flow rates at home, reproducible good volumes. We take the average, we say, you're okay. The single flow rate in the office, we say, that didn't work out okay. You're still not really good. So it makes a big difference because we base decisions on that.
It does, and I think in this era where we're learning more that it's important to get the size of a prostate, whether it's by ultrasound, whether it's by MR, we find many of these jumbo prostates, 100, 125 grams, men deny symptoms, PVRs maybe in the 50, 60 range. Oh, my flow rate's fine, but you start seeing his flow, and in fact, he's voiding in the under 10 consistently. And certainly that raises a whole question. We haven't thought we would treat asymptomatic large prostates, but maybe we need to.
So sounds intriguing, I would say, and I'm in, noting how many patients with BPH and Glattzeit treat. I'm sure my colleagues on the side of reconstruction with strictures are in. I'm sure my female pelvic medicine colleagues are in because they are interested in their OAB type patients, and the volume recording seems to be quite accurate. But there must be a fly in the ointment. Nothing is perfect. So, Ken, what's the limitation right now? How would you say, other than the iPhone version 8, whatever it is?
Well, I think obviously the iPhone is an issue. And I think the biggest issue so far, we have this wonderful dashboard that allows us to be able to see with time the range of their voids, the individual little thumbnails of their individual flow rates, and their volumes, so we can get that information. Currently, I know of no company that can upload it into the EMR. So it's all manual and scanned in data, which is a challenge, but certainly I think this is home flowmetry, as with many home monitoring, not only in medicine in general, but for urology, is in its infancy, and it's only increasing. And as an aside, I wonder, are we going to be able to take, if man's flow rate is variable, are we able to take a cumulative representative flow rate based on an optimal number and then just use that as a standardization to pick up with artificial intelligence when there's changes?
Right. So if I would be a drug company and let's say I had an invention, a new drug for BPH or a new device for BPH, I might just say, let's do that too. Let's do both, the in-office flow rate and let's do the home flow rate, and see how my treatment influences either one of them, because it may also play a role, as far as I can tell, in clinical research, it does seem.
Well, and you even mentioned that in the clinical trials that talked about alpha blockers, there was a change of just a couple
1.5, 2 ml, it's not all that much.
And when we stop and realize, well, if flow rate's variable, maybe we hit it the wrong way.
Yeah, on that day.
On that day
in the clinic. So clearly, what about the technology factor? Some of my patients are, they have an iPhone. I'm not so sure they can use it totally without their grandkids around.
Well, interestingly, the vast majority of the patients have no issues. The typical way I approach it is I start by asking a man if he's in for his BPH. I say, what kind of cell phone do you have? And I get a look like, occasionally it's the flip top, but for most of the time they're wondering, what's this guy going to?
Yeah.
So I find out, do you have an iPhone? Is it an iPhone 8 or higher? No, I don't. Or yes, I do. If they don't, well, okay, how about your wife? And at which point in time, sometimes they do. And so I say, fine, is it an iPhone 8 or higher? I said, fine. I said, by the way, don't worry. You're going to tell her when you get ready to use her phone, you're not going to flow on her phone. And if they don't, how about your grandkids, or do you have any kids at home that you can borrow the flow?
As long as the grandkids don't do the flow rate for the patient.
That's right.
Then we're in real trouble.
Then we're in real trouble.
Then we're just overestimating this a little bit. Well, that was an interesting conversation. Thank you, Ken, for sharing your experience. So turns out that this company, their phone app may just be what the future holds for the management of our patient with a variety of voiding dysfunctions, be it anatomical obstruction, strictures, be it frequency issues, OAB type issues, or be it just a typical man with BPH. And you could see how this tool might help us in the initial assessment, in the follow-up on conservative management, let's just say watchful waiting, or under medical therapy, or after surgical therapy, without the patient really having to set foot in the office, clogging up maybe your patient flow, not being well prepared, having to drink water and wait. And we all know how much of a drag that can be for our patient and for our staff. So it's an interesting new aspect and new way of thinking about medical management. And I believe that wearable devices for outpatient management of a number of things, and to start with diabetes, for example, are beginning to become more and more popular in various aspects of medicine. Well, this isn't a wearable device, but it's an app on one's phone that allows us, the urologists, to monitor one aspect of our patient's lower urinary tract health in a completely new, unexpected way. And I hope you enjoyed this conversation. I thank you, Ken, for sharing your experience and thoughts with us. And I hope you have a wonderful AUA meeting. Thank you very much.